Hello, and welcome to the Cass Health Podcast, the show where we hope to connect our community with healthcare information that's relatable, understandable, and useful to your life, and where you get to know better the neighbors providing your care here. I'm your host, Carter Anderson, and in today's episode, we'll be talking about cancer with oncologist Dr. Seema Harichand. Before we get started, two quick disclaimers. First, the comments in this podcast do not necessarily reflect the views of Cass Health. Second, the information in this podcast is not intended to be construed as personal medical advice. Always consult your primary care provider with questions and concerns regarding your health. Welcome. Thank you so much for taking some time to chat with us today.
Thanks for having me.
Yeah. So we're kind of getting into some rapid fire questions here, just to kind of get to know you a little bit. So first of all, where are you from?
Well, that is a more complicated question than you would think. I guess you could say from Ohio. I grew up in Ohio, but I moved to India when I was 9 and lived there for 10 years.
Wow.
And then I moved back to Ohio to go to college. And then I went to medical school, half in Ohio, half in Miami. And then I did all my training in Atlanta at Emory University. And then I ended up back in Florida for a while. And then I got a job in Iowa, and that's how I landed here. So
awesome. All over the place. The Ohio's, the Iowas, all the different.
Yes.
There you go. That's awesome. Do you have any pets at home?
I have 2 dogs. I have a little tiny mini American Eskimo. Pretty sure she was bred with a Chihuahua, so she has more of a Chihuahua personality. And I have a golden retriever.
Nice.
Who's about a year old.
A good little mix there. That's nice,
Mm-hmm.
those two. If you're cooking dinner to impress, what are we making or maybe ordering?
Oh, I'm ordering it for
There
sure.
you go.
I don't cook. I would probably I might order Indian food. I don't know. I like all kinds of food, Thai food, you name
I
it.
was going to say, do you have like a favorite spot to get takeout from in Des Moines or anywhere like that?
Gosh. Probably there's an Indian restaurant called Bawarchi, and we order from there fairly often.
Nice. There we go. Favorite holiday?
Well, growing up, my favorite holiday was Diwali, which is the Indian festival or the Hindu festival of lights. But my kids and my husband and I also enjoy Christmas very much. We enjoy celebrating that, and those would probably be my top 2, I guess.
Gotcha. What does that first festival, what time of year does that kind of fall around?
It actually is not quite Christmas time, but close to, maybe just a little before Thanksgiving usually. It changes from year to year, but it is, at least growing up in India, it was a really fun time. We had lots of fireworks, and it was a chance to wear new clothes, and we always got together with family and had lots of food and lots of fun.
So it sounds like an awesome time for sure.
Mm-hmm.
What's better, the book or the movie?
Oh, the book, always.
Right, I would agree the book allows for more imagination. Anytime they make a movie after you've read the book, you're like, that's not what I pictured that being like.
Exactly.
Come on. So we will never catch you doing what?
Playing any sports, probably.
Not a sports person. That's
Not a
okay.
sports person.
Right. Driving in the car alone. What are we jamming out to?
I really like Pink and Meghan Trainor, so those are. But I also like Casey Musgraves, so I kind of like a lot of different things. I also love 90s rock,
There
that
you
kind
go.
of stuff.
A little bit
so.
of a mix, but lots of empowering, awesome female artists.
Yes.
That's awesome.
Yes.
High school or childhood nickname?
I really didn't have a nickname. My first name is Seema. It's pretty easy.
Right, pretty.
Not too easy to shorten, so.
Rolls off the tongue pretty
Mm-hmm.
easily, though. So, next or dream travel destination?
Well, my patients and pretty much anyone who knows me knows that I love to travel. I love to see other countries and experience other cultures. Spring break, we were in Turkey, which was beautiful. And on my bucket list, and I hope to check it off this year, is Maldives. So, yeah. We could talk for an hour just about places I'd like to go.
I was going to say, those are places you would like to go. What's your favorite place that you've been then, since you've been so many awesome places?
That is a tough one. I really loved Greece.
That would be awesome, like all the different history.
I
and
love
kind
the
of stuff like
food. I
that.
love the history, and I loved the island of Santorini too, because pretty views, pretty beaches, and just the beautiful blue domes on all the white buildings were just gorgeous. So,
That is awesome. Such a big, wonderful world out there to experience,
absolutely.
right? We always like to hear from people about why they chose their career. So what made you decide to become an oncologist? Was there like a seminal moment that you were like, yes, this is what I want to do with my life?
So my personal experience with cancer was, that my dad was an orthopedic surgeon, and he was an amazing man. And basically my whole life I knew that he had a brain tumor. And the brain tumor was removed in, 1982. And he was able to continue to practice and operate for a little bit longer until 1989 when he had to have surgery again. And then after that, it wasn't too long before he passed away. The tumor came back. And that certainly gave me an inside look at what it's like to be a family member to someone who has cancer. We had to make difficult decisions at the end of his life. And my sister and I were teenagers, but it was just the two of us and my mom, and we made these decisions together. And I've always remembered the impact his oncologist had in helping us through that difficult journey. And this was back in 1991. There weren't a lot of treatments for what he had, yet his oncologist had a huge impact on us. And so that certainly stayed with me. But I really didn't go to medical school knowing I was going to be an oncologist. It was years later when I rotated in the outpatient oncology clinic and had a chance to see, one, patients thriving with cancer, patients being cured of cancer, and the amazing relationship that you get to have with people as an oncologist. This just long-term relationship that is closer than anything I think any other physician can form with the patient and their family. And, we walk through these very difficult experiences together, and we do it as a team. And there are just so many people that I've come to truly love. And it's just so gratifying when you see someone who had stage 4 lung cancer and they're 4 years out, or 5 years. I have a patient I saw this week who was cured of his stage 4 lung cancer. And, that just... I don't think there's any other aspect of medicine that has those big wins. We also have a lot of sadness, but I know that what I bring to the table and what I can bring to the table makes it worthwhile. So, it was sort of something I came to slowly over the course of my internal medicine training as I was exposed to different areas of medicine.
Gotcha. Get to see those people in their most vulnerable positions, right? Highs and lows and all that.
Yeah.
Wow. What are some of the risk factors for cancer kind of generally? That's a pretty big umbrella.
Yeah, that's a very broad question, but there are certainly some obvious ones that, especially things that are modifiable risk factors, things we have control over. The number one would be smoking. That is a modifiable risk factor that people really need to consider and think about stopping if they are still smoking. And really tobacco in any form. So chewing tobacco still puts you at risk of head and neck cancers. Another one that is a major issue in our country is obesity. So obesity does increase your risk of certain cancers. Other ones that are emerging that we need to think about, hard to, living here in the Midwest in Iowa, would be consumption of red meat, certainly consumption of processed meats. Those are associated with GI cancers. And then I think really just things that may be specific to areas like radon in Iowa would be a factor. So if you're able to get radon mitigation, it's something to look into. And then the other aspect of risk factors that we need to consider are family history or genetic factors. And that's not the great majority of patients. It's probably in a relatively small group of patients. But if you know that you have a risk in your family, it's possible to get evaluation by a genetic counselor and get genetic testing. There's a lot to consider if you're doing that. You have to think about its potential impact on your ability to get life insurance, disability, and you have to have all your ducks in a row first. However, it gives you the information you need to be able to potentially take steps to prevent or catch something earlier. So, if you have one of the breast cancer genes, then you could choose to have a mastectomy preventively, or you could choose to have increased screening. You may be able to choose to take medications to reduce your risk. So, knowledge is power, and a lot of times people say they would want to know because it would just be frightening, but it's really, it gives you the information you need to be able to do something about it.
Absolutely. As we age, the risk for developing cancer increases. What should we know about cancer and aging? Is there a relationship there? Are people more likely to develop cancer as they age?
There is a relationship, and that relationship has a lot to do with the fact that, the root of what is cancer? How is cancer caused? Cancer consists of cells that are dividing uncontrollably, right? And how do we get cancer, or how does cancer start? Well, as our cells are dividing, each individual cell, and there's billions, trillions, or whatever number of cells dividing in our body every single day, as those cells divide, the DNA unspools itself and is copied, base pair by base pair. So the analogy I like to make to my patients is that it's like copying the phone book by hand. There's a lot of opportunity for, transposed number, and the same way for a mistake to happen. We have a lot of fail-safes and a lot of mechanisms in place to be able to catch those mutations and fix them. However, if that mutation evades those fail-safes, then that may predispose to uncontrolled cell division. And sometimes it's a matter of an accumulation of mutations over time. And so the longer you're alive, the more times your cells have divided, the more opportunities for that to have happened, for that mistake to happen. The other thing that tends to happen as we get older is our immune system is less robust. And one of the important protections we have against developing cancer is that the immune system identifies and kills off cells that are potentially at risk. And so that combination can certainly lead to increased risk over time. Also, depending on what carcinogens you've been exposed to over time, cumulative exposure over many years also is going to increase your risk. For example, if you're a smoker and you're 20 and you've been smoking for a year, you haven't done that much DNA damage. But if you've been smoking over the course of 40 years, then that increases your risk.
So kind of a little startling statistic here. Iowa has the second highest cancer incidence rate in the U.S., with over 20,000 cases expected for Iowans in 2024. With so many Iowans dealing with cancer, what is the process like for patients as far as receiving a diagnosis?
I think that's very different for each patient, depending on what the diagnosis is. But regardless of whether you're diagnosed with stage 0 or a breast cancer or ductal carcinoma in situ or, stage 3 pancreatic cancer, it's scary to each individual. Doesn't matter that somebody else's situation is worse than yours. And so, the process can be highly variable depending on how it starts. But I think for each person, the minute they hear the word cancer, it's pretty well documented that almost everything you hear after that goes in one ear and out the next. So I think it's really important for patients to know if they think they're going to get some kind of news like that, or if they've had a diagnosis and now they're going to their first appointment to learn more about the next steps. Really important to bring someone with you if you can, and have someone to write things down, because it's a lot of information and the process can be very overwhelming. Once you get a diagnosis of cancer, there's usually numerous additional steps to, more testing that needs to be done, seeing maybe numerous different doctors, depending on whether you need a surgeon, a radiation oncologist, perhaps a gastroenterologist or a pulmonologist, depending on who's doing procedures to make this diagnosis. And so a lot of appointments, a lot of testing, a lot of information coming at you very quickly. So I'd say the most universal term that I hear about the process of diagnosis and, the initial contact with their medical team is overwhelming. It's overwhelming.
That's why that partner, like you said, if you can bring a family member, a friend, someone like that with you to help kind of disperse the flow of all that overflow of information and get as much documented as you can and get
absolutely
have a partner through that
and
journey.
I think the other important thing is write things down. Because myself, I'll walk out of the room after seeing a doctor and think, oh, shoot, I forgot to ask. So write your questions down. Patients often ask me if they can record our visit so they can listen back to it later. And I typically don't have any objection to that, and most people wouldn't. So, ask your doctor if you feel like, if you can't bring someone with you and you feel like you're going to forget, record the visit if you can.
Right, and not only those questions during your appointments, but like when you're at home, when you have questions, remember write those questions down and have them, because your provider wants to help you, right? Help you answer those questions, help you through the journey.
And we're always happy to repeat things if we need to. And I would say, I know it's hard, I know it's frustrating, but try to have faith in the fact that we're there to help you and, lean on us, call if you have questions. But I think the most important thing is just know that you're not alone. There's a team that's there to take care of you, and that, and there's often lots of other support depending on where you're getting your care. There may be additional navigators and people who can provide you support. So if you need that support and you don't have it, don't hesitate to ask. Are there other resources? Are there support groups? Are there navigators who can help me get through this process?
Right, a pool of resources to help make that situation the best that they can, right? Rates of breast, prostate, and lung cancer among Iowans are higher than the national average, and skin cancer is much higher as well. What cancer types are you seeing most often among patients?
Well, certainly breast cancer is the most common cancer among women nationally, and in Iowa as well. And so I do see a lot of breast cancer. It is one of my areas of interest as well. We see all of those. We see prostate cancer, lung cancer, and skin cancer. And, we talked earlier about prevention, so skin cancer would be a good example, right? This is a place where a lot of people are farming, they're out in the sun. So obviously you can't stop going out in the sun, but you can use sun protection. You can wear maybe UV protectant clothes, long sleeves. You can wear a good hat with a wide brim to protect your face from the sun, because once that bell is rung, you can't unring it. So, avoiding the sun damage to your skin is going to lessen your risk. But we see all of these, and, we're treating patients at younger and younger ages for things like breast cancer, colon cancer, lung cancer. And we didn't talk much about colon cancer earlier in prevention, but the age for screening has been reduced to 45 for a colonoscopy. And the number of patients doing it is far too few. And we're seeing just very young patients with colon cancer, even before the age that a colonoscopy would be indicated. So paying attention to things that are abnormal is so important. Oftentimes we'll see someone and they'll tell us, well, yeah, I was probably noticing blood when I went to the bathroom for, the last year or so. Well, that's not normal, and you should see your doctor about it and talk to your doctor about it. A lot of times patients are embarrassed, especially young patients. But knowing that we live in Iowa where we have a lot of risk, why? Well, that's a debate for another day.
Right.
But you need to pay attention to your body, and you need to seek care. And if nothing else, make sure you have a primary care doctor so that you have someone you can go to as a starting point. Because a lot of times patients in their 30s and 40s don't even have a primary care doctor. And, if you don't know where to start, that's the most obvious starting point. So having someone who's your go-to person if something's not going well and is going to be a lot better than going to urgent care and then getting bounced around from there.
We mentioned colon cancer and colorectal cancer specifically. Let's talk a little bit more about women and breast cancer, because I know that's a certain point of emphasis for you. 87% of Iowans are up to date on their PAP and HPV, and 70% are up to date on their mammograms. What other information about cancer is important for women to know, specifically about breast cancer?
So, we've learned a lot in recent years about breast cancer and breast cancer risk. We talked a little bit earlier about family history. So knowing your family history is really important. If somebody has a family history, like let's say your mom was diagnosed with breast cancer at the age of 40, you might need to get screened earlier than that. And if your mom was diagnosed at 40, then the next question is, did she have genetic counseling or testing? If not, should you be evaluated for your risk? There are calculators called the Tyrer-Cuzick score that are now often calculated when you get your mammogram that tell you about your lifetime risk of breast cancer. And if you have a very high risk of breast cancer, like greater than 20%, there may be a role for even starting a medication to reduce your risk, even if you don't have a genetic mutation that puts you at risk. For patients who have dense breasts, particularly if they're very dense, there may be a role for MRI screening in addition to mammogram, so that you would get breast imaging every 6 months mammogram once, MRI 6 months later, so that you're getting, one or the other every 6 months. And, these are just tools to get more sensitive imaging, because mammograms may not detect breast cancer in women with very dense breasts. So knowing that you have a family history, the starting point, again, to get back to your primary care doctor, is talk to your primary care doctor about whether you need enhanced screening, about what age you should start getting screened, whether you need genetic counseling or testing, things like that. And the most important thing is, if you are young, below the age of a mammogram, and you notice something in your breast that feels abnormal, if someone tells you, oh, you're too young, 30-year-old women don't get breast cancer, please don't listen to them. Look for another opinion. If something is evaluated with ultrasound mammogram and it looks okay, that's fine. But at least make sure that if you feel something is wrong, you listen to your body and get that evaluated.
Right. Never second guess yourself or your intuition, because it could be...
At least make sure that it's evaluated if
Right.
you're concerned about it, because we do see young women who get diagnosed at a later stage because they were seen by someone who said, oh, you're too young, it's not breast cancer. And so if you feel something is wrong, or if you got evaluated and they didn't think it was anything, but it's growing or changing and there's something going on that concerns you, go back. Because a lot of times the other thing that will happen is people get discouraged that, well, they didn't think it was anything. So if you feel something is wrong, listen to that, get it evaluated. Like I said, if you're having blood in your stool, if you are, experiencing something that is abnormal, get it evaluated.
Right. It's tough to be an advocate for yourself, right? Like that in those situations, continue to push and advocate.
Yeah, most of the time, if you're 30 years old and you feel a lump, it's probably a fibroadenoma, it's probably benign. But if something doesn't seem right, if it's growing, if it's, changing in a way that you feel is concerning or alarming to you, go back and seek care again. If it ends up being just reassurance that you got an ultrasound, it doesn't look suspicious, that's great. But if it's concerning to you, at least have it evaluated, because that's how we can avoid missing things in those young patients.
Right. And then that gives you guys the precious time that you need to help reverse and control those things if something is wrong.
Correct.
So we just talked a little bit about cancer with women. Are there particular types of cancers that impact men more than women?
Well, certainly prostate cancer is something that's unique to men and is, again, for men, the most common diagnosis. Thankfully, it's not the most common cause of death in men, just as breast cancer is not the most common cause of cancer death in women. It's lung cancer currently. But for both men and women, prostate cancer is still a significant cause of morbidity and mortality to men in this country. And PSA screening used to be more universal. There have been some changes to the recommendations, and so we see that happening less often. But if you're African American, if you have a strong family history, those would be things to alert you that perhaps you should get screened and discuss it with your primary care physician. And again, family history can be important here, because if you have a strong family history of prostate cancer can also have a genetic basis. And it's not always just a family history of prostate cancer. So if your mom had breast cancer and your grandmother had breast cancer and you're a man, depending on the specifics of their history, it could be that they had the breast cancer gene, and that can actually cause prostate cancer in men. So important to know. It can be associated with pancreatic cancer. It can be associated with other things. So, having good understanding of what your family history is important for you to know and for you to share with your healthcare providers, so that they can maybe clue into things that you may be at risk for based on that.
Gotcha. That's what I wasn't sure. I was going to ask you that as well, like the different genetic predispositions, if that impacts, like you said, with breast cancer, if that means that someone like a male would be at risk for prostate cancer. So that is.
So a male could be at risk for breast cancer as well, if they have the BRCA gene, but they can be at risk for prostate cancer, pancreatic cancer, and some other cancers as well. So there are many different genetic syndromes that can sort of cluster different types of cancers together. And so the main thing is just to have a good understanding and talk to your family. A lot of times people are like, well, I don't really know what they had. But trying to understand what your family history is can be important. If you end up getting diagnosed with something, to be able to find out if there is a genetic basis for it.
We like to give out useful tips, tricks, good to know information. What are some of your favorite oncology words of wisdom, encouragement, or for those dealing with a cancer diagnosis?
So I would say that the most important thing is to keep in mind that talk is cheap and everyone has an opinion for you. Everyone. When you get diagnosed with cancer, lots of people will tell you lots of things about what they saw on the internet, and you should eat frozen lemons and use your cow's deworming medication and whatever other things they tell you. Take the information. Feel free to come and ask us about it. But be cautious and be wary of what everyone's going to tell you. Remember that you have a team that's there to take care of you. I encourage people to trust their physicians. I'm not saying that every physician is perfect, but, if you're putting your faith in someone to get you better, you need to trust us. I'd encourage someone going through a cancer diagnosis, particularly if they're getting treatment with chemotherapy, to call your doctor if you're having trouble. To try to follow the instructions we give you because we're trying to help you. And most importantly, try to keep the lines of communication always open. If you're concerned about something, if you have doubts about something, if you want a second opinion, talk to us. I have plenty of patients who I send for second opinions, and I have patients who just want to go to be sure that they're getting the right treatment. And you should never feel bad about talking to your doctor about things like that. If you want a second opinion, you should get one. And so I just think that one of the things in recent years that has been more challenging is having a good therapeutic relationship with your patients. There's a lot of conspiracy theories out there. There's a lot of, the internet's really changed things. There's a lot of bad information out on the internet. And if you feel like you don't have a doctor that you can trust, then find a different doctor, because you need someone who you can talk to and you need someone who you can work with, because it's always going to be a partnership. It's not a one-way street. I don't just tell someone what to do. I give them recommendations and advice, and I try to answer all the questions they might have about those recommendations. And I try to work with people if they want to try alternative things, but I also make sure that they know that I'm not going to endorse anything that is potentially harmful to them.
Right. You're going to give them, here are our options within reason, and then they can pick the option that's best for them, right?
Right.
Awesome.
Where the dog deworming medication is usually on my, I really don't recommend that.
No, we're going to pass on that one,
Yes.
right?
Yes.
So when we were talking about why you want to get into oncology, you mentioned that you saw your father go through a cancer diagnosis throughout the end of his life. How has cancer and oncology changed from that point to where it is now today?
So from that point, 1991, 33 years ago, it's changed tremendously. Hard for me to know. I was 16 then, so I don't know a lot about enough details about his diagnosis to know if things could have been different for him today. But honestly, I suspect they could. I've sent patients to Mayo Clinic where they've done, brain surgery while the patient was awake so that they could preserve certain areas of the brain. Things have come a long way. But for my own experience as an oncologist, so I completed my training in 2009, so that's 15 years I've been in oncology. In that time frame, the change has been unbelievable. It's why I'm still excited about coming to work every day. So, in the time of my training, which was 3 years, my specialty training as an oncologist, there were maybe, 10, 15 drugs approved. There were probably 10 or 15 drugs approved last month. We went from, in lung cancer, it's a topic I wrote papers on, targeted therapy in lung cancer. We had a drug called Avastin that was relatively new. And it was very exciting because for stage 4 lung cancer, survival increased from when we had, one chemo drug to combining it. It went from 4 to 6 months to combining with a platinum drug. It went about 8 to 10 months. To adding Avastin, it was 12 months. Now, with immunotherapy, drugs like Keytruda that many patients have heard about, middle of the road for stage 4, probably 2.5 years. What if you have a mutation that we can target? I have a patient who had stage 4 lung cancer, metastases everywhere. She's been on the same pill for 6 years with no evidence of recurrence.
Wow.
It is remarkable. We see patients cured of stage 4 cancer, kidney cancers, things that are sensitive to immunotherapy. We have targeted therapies. We have just all these new sort of precision medicine is a new sort of buzzword that we hear, but it really is remarkable. We still have so far to go. We still see lots of, I have so many wonderful people that I have lost because their cancer didn't respond to therapy. So I don't mean to say that, cancer's not a problem anymore, we'll just cure it. But the change is remarkable. The change in side effect management is dramatically different. When patients tell me about they knew someone who was treated 35 years ago, one of the things I spend a lot of time explaining is that we have a lot better nausea medicines. We have better supportive care medications now. So it's really been gratifying to see the change in oncology, and I know it's only going to continue. The research continues, and we're going to see more and more patients cured and see more and more patients treated with better quality of life. And, that's what keeps me engaged and keeps me, excited to go to work every day.
That is a fabulous answer. And I'm sure, like you said, that 15 years now, it'll be wonderful to see even the next 10, 15 years, what's going to happen, those advances.
So one of the senior partners in my practice, he's in his 80s, and he often likes to joke that we only had 3 drugs that we used for everything back when he started in oncology. And now it's really amazing. You'll have a patient who has a very particular mutation in a rare cancer, and when you start them on that drug that we have to target it, they'll ask me, what have your patients experienced before? And I have to honestly answer them, I don't know. I've never used this before. I never had the right patient. But now we have these drugs that are so specific to very individual scenarios that, there's all this new stuff out there. And yeah, it's the change will just keep coming. The pace will continue and probably accelerate further. And, I think the sky is the limit for where we can go. But like I said, we still have a long way to go. It doesn't take away from how difficult a diagnosis can be today and how devastating an impact it can have on someone's life. I certainly recognize that a diagnosis, especially of something like stage 4 cancer, impacts somebody's ability to work, their ability to do things with their family, and most importantly, to be there as long as they'd like to with their family. And I certainly hope that someday we can say that's not the case anymore. I do think that a lot of people have an idea that cancer is one entity that can be cured, and that's not the case. Cancer is just hundreds of different thousands of different diseases. But the more we learn about the biology of cancer, the better we get at treating it. And, in the meanwhile, the important thing to know is that those of us who choose to go into oncology choose to do so because we really want to make an impact and take good care of patients. And one of the reasons I came to Iowa is I was really not happy in the practice I was in, and I came here because where I work in Des Moines, but also what we've been able to bring to rural communities, I work with a group of doctors who really feel like patients come first. And that's always been the philosophy of our practice, of all of the employees who work in our practice. And, I'd like patients to know and trust that we really do feel that way and that we really have their best interest at heart. And hopefully, they will sense that and trust us to take good care of them, because that's what we're here for.
A partner through that journey, right? Thank you so much for taking some time to join us today. This has been awesome.
It's my pleasure.
Yeah.
Thanks for having me.
Yeah.